This presentation is on falls and fractures and how to modify your risk. My name is Benjamin Pierce, and you can get more information on my website below, planetbenja.com. Well, how serious is the problem? 90% of the 300,000 hip fractures in the U.S. each year are the result of a fall. 10% of the hip fractures occur spontaneously due to low bone density or osteoporosis. Someone can be standing there talking to you and then have a spontaneous fracture and go down. Women 2 to 3 times are more susceptible to hip fractures than men. Postmenopausal women, well, they have a 1 in 7 chance. Hip fracture increases at the age of 50, doubling every 5 to 6 years. More than 1/3 of adults 65 years of age and older fall each year. Nearly 1/2 of women who reach 90 will have suffered a hip fracture. Outcomes linked to falls, well, they're the leading cause of injury deaths in America. Most common cause of non-fatal injuries and hospital admissions for trauma. More than 60% of people who die from falls are 75 years of age and older. After a fall, 20 to 30% suffer moderate to severe injuries, such as hip fracture or head trauma that reduce their mobility. Each year, 300,000 Americans suffered fractured hips. National Safety Council reported in 2005 there were 37,000 unintentional injury deaths in the home. 17,000 of them were from falls. Outcomes linked to fall: only 25% of hip fracture patients will make a full recovery. 40% will require nursing home care. 50% will need a cane or walker to safely ambulate. 24% of those over 50 will die within 12 months. Each year, women suffer more osteoporosis-related fracture than strokes, heart attacks, and breast cancer combined. So what happens after a fall? Well, this is a study of fatal and non-fatal injuries among people 65 years of age and greater. Well, 1% of them died, and 24% were treated in emergency department and hospitalized. 76% were treated in the emergency department and released. And there's probably millions of fall-related injuries that go unreported. Outcomes linked to falls. Falls are the leading cause of traumatic brain injuries. Among older adults, the majority of fractures are caused by falls. 5% of older adult falls cause fractures. Most common fractures are the fractures of the vertebrae, the hip, the forearm, leg, ankle, pelvis, upper arm, and hands. This chart is interesting. It is a list of deaths per year of the most common causes of accidental death. Of course, motor vehicle crashes are number one, 43,000 accidental motor vehicle deaths per year. But falls is number 2 with almost 15,000 per year. So it is a significant problem. Just in New York State, the fall frequency and consequence for people greater than 65 years of age, well, an average of 132 people daily suffer a fall serious enough to require hospitalization. 1 in 6 falls results in a serious injury, such as a head injury, soft tissue damage, or fracture. 2.4 deaths per day can be attributed to falls. The recognized industry standard for falls risk assessment is the Morris Fall Scale. Morris Fall Scale considers 6 things: history of falling, immediate history of physiological falls, that is falls from seizure or impaired gait. Second, secondary diagnosis, if more than one diagnosis is listed on the patient chart. Ambulatory aid, walker, cane, or crutches for support. Intravenous therapy, gait, if they have a weak or impaired gait, and mental status, if they overestimate or forget their limitations, which is very common, especially among the elderly. Common causes of falls in the elderly. Well, accident, environmental hazard, fall from your bed, gait disturbance, balance, disorder, or weakness. Many people fall because they have a pain related to arthritis. People fall because of vertigo. Medications can cause people to have lower blood pressure or alcohol. Acute illness, confusion, cognitive impairment, postural hypotension, visual disorder, central nervous system disorder, syncope, drop attacks, epilepsy. All these things are common causes. Common presentations for elderly falls on the same level. We're going to talk about falls on the same level and then falls from one level to the next. A mechanical fall while attempting to reach the commode. They trip and fall on the carpet. Mechanical fall after standing up. Maybe they stood up too fast. Walking in the house, lost balance, fell, striking their head. Slipped while in the bathroom. Mechanical fall in the shower. Backwards fall from a walker. Mechanical fall while dressing and striking their head. Common presentations for elderly falls from one level to the next. Fall while transferring from wheelchair to chair, which is very common. And also from a standing position to a wheelchair. Mechanical fall while attempting to sit on a chair. Rolled out of bed to floor while getting up. Fall while attempting to get out of bed to the walker. Fall from floor while sitting on the commode that slipped out from underneath. That's a portable commode. Became dizzy, stood up and became more dizzy, falling onto the ground and striking head. Stumbled and tripped on low curb and fell to the ground. Missed bottom step and fell, and also standing on a step stool. Seniors should never be standing on a step stool. I love these mnemonics. This one's called I Hate Falling. And these are typical reasons for people that fall frequently. I stands for inflammation of joints or joint deformity. H stands for hypotension, orthostatic blood pressure changes. Somebody gets up too long, or they've been seated too long, and then they stand up and become dizzy and fall. A, auditory and visual abnormalities. T, tremor, Parkinson's disease or other causes of tremor. Equilibrium is E, balance problems. F is foot problems. Many of these are correctable. People often neglect their foot issues until it causes them a serious medical problem. A for arrhythmia, heart block, or valvular disease, AFib. L, leg length discrepancy, especially for people who had hip or knee replacement. Often they end up with a slight discrepancy in their leg length. Lack of conditioning, generalized weakness. I for illness. N for nutrition, poor nutrition or weight loss. And G for gait disturbance. So, how do you modify your risk factors? Well, number one, you're increasing the lower body strength and improving balance through regular physical activities. Seniors who are mobile and walk regularly keep their joints and muscles limber and reduce their risk of falling. Wear supportive, low-heeled shoes, even at home. Avoid walking around barefoot in socks and stockings, floppy backless slippers. Seniors who are sedentary and allow their muscles to atrophy are really high risk for falling. And considering that most physical therapy is often approved by Medicare, people should start getting physical therapy as soon as you start seeing them become sedentary. Also, arrange with a family member or friend for daily contact. Try to have at least one person who knows where you are every day. Proper nutrition can help reduce the risk of falling. Seniors that are undernourished are often unsteady on their feet, can even feel dizzy when they stand up. Inadequate nutrition can also lead to a number of other health failures and diseases that further destabilize the body. Proper diet and exercise can significantly improve strength and endurance, which can mitigate your fall risk. Now, medicines. Medicines can affect gait and balance for most adults. Limiting the number of different medicines that one is taking can help to stabilize and reduce fall risk. Ask the doctor or the pharmacist to review all your medications, both prescription and over-the-counter, to reduce side effects and interactions between them. And don't forget to get regular checkups. Regular checkups can keep you healthy and mitigate your fall risk. It may be possible to reduce the number of medications used, particularly tranquilizers, sleeping pills, and anti-anxiety drugs, People who are on sleeping pills that have to get up often in the night to go to the bathroom are very vulnerable to falls. Talk with your doctor about having a bone mineral density test, BMD test. The most widely recognized bone mineral density test is called a dual energy X-ray absorptiometry, or DXA test. It is painless. It's a bit like having an X-ray, but with much less exposure to radiation. It can measure bone density at your hip and also at your spine. It does require a prescription from your physician. The dual energy X-ray absorptiometry mainly scans your hip and your spine. It's painless, it's non-invasive, very safe, low dose, and it will determine the mineral content in your bone. Studies have shown that some other important fall risk factors are Parkinson's disease, history of stroke, arthritis, dementia, cognitive impairment, and visual impairments. To reduce these risks, seniors should seek a healthcare provider regularly for chronic conditions and have an eye doctor check their vision at least once a year. Seniors with dementia tend to be less careful when they're ambulating, especially people with Alzheimer's, than their non-demented counterparts, who are constantly aware and fear of the consequences of a fall. Calcium supplementation and estrogen are effective in preserving bone density in postmenopausal women. In a randomized trial in healthy postmenopausal women, calcium supplementation slowed bone loss and significantly reduced symptomatic fractures. Numerous studies suggest that risk of fracture can be reduced 25 to 50% by estrogen replacement therapy as well. All women should also receive counseling regarding universal preventative measures related to fracture risk, such as dietary calcium and vitamin D intake, weight-bearing exercise, smoking cessation from their physician. Here's a home safety checklist that can help improve the safety of your home and remove trip hazards. And in your living spaces, remove throw rugs, secure carpet edges, remove low furniture and objects from the floor, reduce clutter, remove cords and wires on the floor that people can trip over, or cover them up securely. Check lighting for adequate illumination at night, especially the pathway to the bathroom. There are cheap modifications that can be made for motion detector light switches, so that when the person enters the bathroom, they don't have to fumble around for the switch. It'll automatically turn the light on for them at night. Secure the carpet on treads and stairs. Install handrails on staircases. Eliminate chairs that are too low to sit in and get out of easily. Avoid floor wax or use non-skid wax. Ensure that the telephone can be reached from the floor and not just solely mounted on the wall. There needs to be an extension that can be reached when someone is laying on the floor. Bathrooms. Install grab bars in the bathroom and shower and by the toilet. Use rubber mats in the bathtub or the shower. Take up the floor mats in the bathtub when the shower is not in use. And install a raised toilet seat. Those are inexpensive and they can just sit right into the toilet. Also, the grab bars can be attached to either side of the toilet by being mounted right to the seat bolts. Outdoors, repair cracked sidewalks, install handrails on stairs and steps, trim the shrubbery along the pathway to the home. A lot of times those people have lived in their homes for 30, 40 years, and those little shrubs that they planted when they moved in have grown up and over the sidewalk. And many people suffer falls and fractures because they get their groceries hung up on branches of their shrubbery, and it trips them up and they fall. Install adequate lighting by the doorways and along the walkways leading to the doors. Now, these are resident falls per 1,000 patient days that I've collected over the years. Nursing home, there's usually about 8 falls per 1,000 resident days. In assisted living, 6, and in a company that I ran called Potomac, we managed to get it down to 3 by doing falls and intervention, and I'll detail those for you now. Organization and philosophy need to support family and residents' rights to risk-taking, autonomy, and self-determination. From a resident's perspective, individual desires and needs need to be central to the safe application of the guidelines. Family and the resident is an active participant around decisions regarding his or her care relating to these guidelines. So you need to have guidelines regarding falls intervention, and you need to respect people's need and willingness of self-determination. Environmental, in the bathrooms. Grab bars near tubs and showers. Showers with access ramps to the shower stalls. Large bathrooms can accommodate caregiver and resident together. Handicap and raised toilets. Padded floor mats with rubber base. Handicap accessible sink with lever activated faucets. Non-slip flooring. Accident lighting. Motion detection switches in each of the bathrooms. Handrails in the common areas, handrails in the stairwells, secure low pile padded carpeting, carpeted stairs. You can get these stop signs at the bottom of staircases if people are prone to go up and down the stairs, especially people with dementia, and they attach to either side of the staircase with Velcro straps. Color scheme for visually impaired. Make sure you have excellent lighting. The better the lighting, the less the fall risk. High profile sofas for safer access. So a double height sofa, so it's easier to sit into and get out of safely. You can use recliners for safer positioning. Correct chair height to facilitate wheelchair transfer. Dining tables need to be about 31 inches to accommodate wheelchairs to slide underneath them, and also to provide additional support. Of course, the absence of electrical cords and low furniture, which can pose tripping hazards. From a medical standpoint, it's important to have quarterly evaluation by physician of health status, medication review for polypharmacy and psychotropic drug regimes. It's important also to track the use of sedatives, hypnotic, and antihypertensive drugs, and other medications which can affect people's gait and balance. Most importantly, evaluate the necessity of benzodiazepines. And here's a list of benzodiazepines here below. If you can get people off of those benzodiazepines, they're basically antipsychotic, anti-anxiety drugs that are commonly, especially Ativan, Ristarol, are commonly prescribed to people with dementia. Explore alternatives to psychotropic medications, including keeping people busy and keeping them active. People have a tendency to fall that are not active or not engaged. Monthly tracking by the RN clinical director. Regular podiatrist visit to monitor foot health. This is also Medicare reimbursable. Physical therapy consultation if physician ordered, also Medicare reimbursable. Training available by the physical therapist to safely use an appropriate safety care device. A lot of people don't know how to safely get in and out of a wheelchair. From an operational, programmatic standpoint, it's important to have morning stretches and exercises for strength training. A lot of falls occur in the morning while people still have the cobwebs in their brain from their night before. A sitter-size program for wheelchair residents. Walking around twice a day, or weight-bearing exercises, music therapy, and dancing to build strength and balance, art projects to sharpen motor skills and keep eye-hand coordination tuned in, games designed to sharpen eye-hand coordination with motor skills, and also to keep muscles and joints limber. From a provision of care standpoint, there should be a falls risk assessment upon admission, and then quarterly or if there's a condition change. Transfer assistance should be provided every 2 hours during the day, toileting schedule. There should be half-hourly rounds throughout the night. There's also tabs personal alarms can be available for bed use. That's an alarm that is attached by a lanyard and a clip to an individual's clothing, and with the other end attached to a magnetic sensor. And as soon as the tab is removed from the magnetic sensor, it sets off an alarm. Bed rails for safety. We've also put people's mattresses on the floor people who had trouble getting in and out of bed, or people who are susceptible to wandering at night. Putting the mattress on the floor helps keep them safer. And also, there's available a device called a hip protector for high-risk residents. Now, these hip protecting devices is just a shield that fits into a specially designed garment, and it can greatly reduce hip fractures. And most hip fractures really occur as a result of falling sideways and not from compression. Operational, again, a nutritional program should be designed by a dietitian to address nutritional needs of dementia population, keep them strong and healthy. Weekly weights should be taken to alert for unexpected weight loss. You should select foods high in calcium to address osteoporosis prevention and when the meal planning is done. Promote exposure to sunrise to combat vitamin D deficiency. Orienting residents to the home, their bed, area, how to summon help when they need it. These are people who are new to the building. The better you can orient them, the less likely they're going to wander around seeking things and exposing themselves to a potential fall situation. Okay, there are therapeutic options for preventing and treating osteoporosis. Calcium supplementation can be used 1,000 to 1,500 milligrams per day. Vitamin D supplementation, 400 to 800 per day. Phosphonates can be used, Fosamax, selective estrogen receptor modules, calcitonin, regular physical activity, weight-bearing exercise, muscle strengthening exercises, reduction of modifiable risk factors such as smoking cessation and alcohol avoidance, fall prevention, use of assisted devices, home safety practices, physical therapy for gait stabilization, and also anabolic steroids, pulsate growth hormone, parathyroid hormone therapy. These are all things that can be used to help treat osteoporosis. And also to improve your balance. Practice balance exercises every day. Here's 3 exercises that are useful. While holding the back of a chair, sink, or countertop, practice standing on one leg at a time for a minute. Gradually increase the time. Try balancing with your eyes closed. Then try balancing without holding on. While holding the back of the chair, sink, or countertop, practice standing on your toes. Then roll back to balance on your heels. Hold each position for a count of 10. While holding the back of a chair, sink, or countertop with both hands, make a big circle to the left with your hips and repeat to the right. Don't move your shoulders or feet and repeat that 5 times. If you do those exercises, or one or more of those exercises a day, you're certainly going to improve your balance. Osteoporosis, bones of contention. Basically, it's a systematic skeletal disorder characterized by decreased bone mass and deterioration of bony microarchitecture. It results from a combination of genetic and environmental factors that affect both peak bone mass and the rate of bone loss. Factors include medication, diet, race, sex, lifestyle, and physical activity. Okay, boning up on osteoporosis. It's a skeletal disorder characterized by the compromised bone strength, disposing a person to an increased risk of fracture. So you see the normal bone matrix is dense on the left, and osteoporosis bone matrix on the right is showing a loss of the microarchitecture. World health factors for osteoporosis: age, previous fracture, family history of fracture, smoking, excessive alcohol intake, low body weight, steroid use, low bone mass, estrogen deficiency, and also poor intakes of calcium and vitamin D. Okay, so what happens when you get a hip fracture? The doctor will x-ray the hip to determine exactly where the bone is broken and how far out of place the pieces have moved. Most hip fractures are one of 2 types: femoral neck fracture, which are 1 to 2 inches from the joint, and introchanteric fractures, which are 3 to 4 inches from the joint. I'll show you pictures of each. These are the various types of hip fractures. Treatment. Modern treatment for hip fractures aims to get you back on your feet again as soon as possible. The doctor will reposition the fracture and hold it in place with an internal device. A femoral neck fracture are usually stabilized with surgical screws or pins. These are used if you are younger or if your broken bone is not moved much out of place. If you're older and less active, you may need a high-strength metal device that fits into your hip socket, replacing the head of your femur. For introchanteric fractures, a metal device, compression screw and side plate, holds the broken bone in place and allows it to heal, so the head of the femur can move normally in the hip socket. The recovery? Well, recovery depends largely on the extent of the injury and the overall health and fitness and attitude of the patient. Some patients respond readily to physical therapy and rehabilitation, especially those with positive attitudes and cognitive awareness. Others, who are less cooperative, are more at risk for prolonged recovery or further decline. Ample research has demonstrated the mind's ability to influence our health and recovery. People who suffer a hip fracture are often experience a sense of helplessness and despair, which can lead to depression. Helping victims through their rehabilitation and recovery through positive reinforcement can often dramatically influence the results. Returning them to their home unsupervised could prolong the recovery process and subject them to re-injury. So consider a supportive environment where trained staff can assist with therapy and aid their recovery. Just a couple of words on vitamin D and calcium. Studies in elderly patients found that supplementation with calcium and vitamin D resulted in fracture reductions by 22 to 50%. So doses in vitamin D greater than 800 IU per day are needed for this benefit. So strongly consider going on a vitamin D regimen. Here's some additional resources. Visit the National Institute of Health, Osteoporosis and Related Bones Disease National Resource Center, the National Institute on Aging, and also the Food and Drug Administration. Again, my name is Benjamin Pierce. Additional information and reading can be found on my website, planetbenja.com, and there's also some links to ebooks on Amazon Kindle. Thank you, and I hope you enjoyed the presentation.